Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sarah Reiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Kate Mihevik-Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Okay, so today's case, we're going to jump in as usual, just make sure we don't keep you guys too long, is we are going to talk about an ankle sprain and ankle instability. So this particular case is a 38-year-old ultra marathon. This athlete is a male, and he comes into Sarah with bilateral, so both side, lateral, which means outside, hip pain and back pain. But the right is worse than the left. And when he gets into his appointment with Sarah and he's talking about things going on, he just casually mentions that he chronically sprains his ankles. That's just part of what happens to him, and it's happened for a long time. So, Sarah, if you want to take over and talk a little bit more about this case and what we're looking at here, that would be great.
Yeah. So the way this case kind of shook out is he came in, had some lateral hip pain. We got some x-rays, looked like he had signs of hip impingement. So pincer and cam shape of the hip that makes it more likely to pinch some of the soft tissue structures and also cause some mechanical issues in the hip. When I saw him, he'd taken a couple weeks off and actually was feeling really great, because the other thing that I always worry about is anyone with some kind of hip or groin pain, could they have a stress fracture? So first thing we did is rule out, do we need to get urgent imaging? Do we kind of put everything else aside and figure out what's going on from that standpoint? And that was not the case. So we were looking at more kind of a chronic type of scenario and a little bit of arthritis in the hip joint as well. So questions I always ask whenever folks have hip pain, number one, is we start looking up and down. So looking proximally to the core and then also getting all the way down to the foot. And so I always ask, have you had any other injuries? Is there ever anything that you find yourself stretching all the time or that feels tight? And they're like, oh, well, nothing recently. I'm like, no, all the way back, like high school, like your entire lifetime, right? So all these things stick with us. So he mentioned that he'd sprained his ankles a fair number of times and still does, and really doesn't really affect him. I always ask, have you ever had a time you've been on crutches or in a boot? Like it was severe enough they had trouble weight bearing? And he said, yes, it's happened on both sides. So a pretty significant amount of ankle sprains that he's had in the past. And when we say ankle sprains today, we're going to talk more about lateral ankle sprains, so sprain on the outside of the ankle as opposed to the inside, which is how we think about rolling your ankle or an inversion sprain. So as we get to the exam, a couple of things that I think is really interesting and seems counterintuitive to a lot of folks is that he had areas where he had lots of tightness and then areas where he had incredible hypermobility. And especially someone who's getting into midlife, some of those things are going to kind of change and adjust. And so in being mindful of that, he could put his palms on the floor, for example, and then his ankles were super loose, but then his hips were super tight. And so kind of looking at these different patterns and not assuming just because one joint is loose, everything else is loose. Anyway, we got to the point that really we ended up talking a lot about his feet and his stability, and then also trying to work on mobility in his back and his core. And this shifted very much to a more kind of holistic long-term conversation, which I always enjoy in my offices, where they say, oh, I didn't even think I should come in. I'm like, no, I'm so glad you're here. Because this is exactly what I like to do is folks who are still able to be active. And I told them, you're not forbidden from running, but we need to work on some things to get some PT under your belt before you start progressing. So I would love to hear what Kate might do in these scenarios and kind of how you like to manage ankle instability and get into the nitty gritty about why ankle instability is so important to address and not ignore.
Yeah, sure. I'd love to, of course. So much like Sarah, I would go through an extensive evaluation and look from, hip all the way to feet, because if he does have that back and lateral hip pain, we'll probably end up treating that as well. But much like Sarah said, chronic ankle stability is something that many runners think is nothing. They just always come in and they're like, oh yeah, I sprained my ankle, no big deal, let's move on, because it doesn't really hurt that much and it doesn't really keep them from running. But if you continually sprain your ankles, what happens is that those ligaments begin to stretch out over time. So you have three ankle ligaments, lateral ankle ligaments. So ATFL, so anterior talofibular ligament. And then you also have CFL, calcaneal fibular ligament. And then you have PTFL. So these are always so funny, right, to go through these. Posterior talofibular ligament. And these three ligaments all work to help create stability on the outside of your foot. Now, they're not the only thing that creates stability, right? So some of your muscles create stability and tendons that go through that area do as well. But what your ligaments are made of is collagen. And that collagen, every single time you sprain your ligament, it gets disordered and kind of like looks like I don't know, mincemeat, like breaks up, right? And then what has to happen is that those ligaments have to come back and start lining up in the line of stress. Like, so the stress that we put on those ligaments, we want them to be able to tolerate that stress. But if you continually sprain that ankle and stretch it out, eventually it's not going to go back to the amount of stability it used to be. I read an article a long time ago that said, every time you sprain your ligament, you lose 2% of the stability in that ligament. So if you think about that, the first time you sprain it, you end up with, if you come back all the way from that ankle sprain, you're at like 98% stability. Then the next time you're at 96, and then so on and so forth. So if you continually sprain your ankles, you're constantly losing stability. And that is a concept I love to tell my runners because, like I said, nobody seems to care about ankle sprains. The other piece about ankle sprains, and this was another research paper that I read several years ago, and I told Sarah and Kelsey that I have to pull it up because the paper said that when we sprain our ankle, it changes how our glute functions on that same side. And if we think about it, a lot of times when your ankle is unstable, a lot of other things have to start taking up the slack. So we often see lateral hip pain or back pain when you sprain your ankle over and over because of the lack of stability, the change in the way our foot hits the ground. So we start to get in more of a supinated position and we start loading the outside of the leg. So it could be lateral hip or it could even be lateral knee like IT band, right? So all of these things are important and it's a huge part of my education around ankle sprains. But the question you asked me, Sarah, was not any of that. You asked me what I would do. So
We have to start somewhere.
That's right. So that would be the educational component. But from like a PT standpoint, what I would definitely do is work on overall stability, work on foot control, think about mobility. So if there's somebody that's constantly rolling their ankle, that subtalar joint, so the joint that goes in and out. So like if you're thinking about, is your foot rolling in or out? That's your subtalar joint. So that might get a little bit stuck in that out position. So I'm probably going to have to do some mobilization in the foot. I'm also going to have to mobilize the tib-fib joint, which is the fibula runs next to the tibia on the outside of the foot. And that little bump on the outside of your ankle is called the lateral malleoli. That's the bottom of the fibula. So I would be definitely doing some mobilization there. I would address the ligaments themselves. I would do some deep friction massage to help the ligaments themselves start to realign from a collagen standpoint. But then most importantly, we would work on a lot of balance, a lot of foot control. We would make sure that the person knows how to really work through their big toe as well as their fifth digit and into that heel, knowing how to use their arch and how to do things single leg, and then move them through plyometrics. Can they maintain the stability of their foot and ankle during plyometrics, which is essentially running in place? So that very long answer is a lot that I would do. There's so much more, but I would love to pass this on to Kelsey and come back a little bit later. Go ahead, Kelsey.
Yeah, and I think what is funny for the audience to pick up on, you just talked about all of that, and I'm only joking on you because I'm the exact same way. But then when I was asking about what exactly comes with an ankle sprain while we were prepping for the show, you were confused about the number 3. So without a beat, you rattled all of that off, but 3. Okay. So, you talked a lot about collagen in there, and obviously through our other episodes, I've talked a lot about how when we're not fueling enough and doing ultra running is no easy feat. So, not only are they fueling for one long run a week, oftentimes their multiple runs throughout the week require preparing like it's a long run just because of the pure time on feet. That's the one of the biggest transitions that when I take ultra runners on, I'm like, okay, actually, three of their runs are the length of what, a normal road runner that's maybe trained for a half or a marathon is. So, really easy to underfuel. And when we're underfueling, collagen turnover isn't as efficient, and that's going to delay healing. Also, I think it's really important to distinguish between the types of collagen in here, because the type of collagen that you might supplement with for like a knee cartilage might look a little bit different. And it's confusing because we go into the drugstore and there's a million different ones just because it's a hot supplement right now. Because there is a little bit of research, right? And so type 1 and type 3 are the ones that are going to support ligament healing the most. And when ligaments first start healing, at first you talked about the disorganization. They're more disorganized. They're the type 3, and then it transforms as it gets stronger and further along into the healing process as type 1. And so when you're purchasing a supplement, looking for hydrolyzed peptides that are either type 1 or type 3 from bovine or marine are going to be most efficacious for a ligament after you've kind of satisfied that you're not under fueling. Another thing that I think about, especially we were talking about how March is kind of this back and forth weather, not that we see these issues outside of changes in weather too, but this runner might actually not be acclimated. So that's going to change their hydration. So their thermoregulation is a little bit off relative to like July. So if it was snowing like it was here in Denver last weekend, but 85 degrees during my long run, I'm not acclimated to that run. So I'm going to lose fluid at a much faster rate. And so hydration is really important because electrolytes influence things in our mechanics like our proprioception, our motor unit recruitment, and our reaction time. And I think with ultra running, those are really important skills that road running we're not having to deal with quite as much. And so even electrolytes like sodium is going to influence the nerve signaling. Potassium has a big role working with sodium with the signaling and the firing of muscles. And then calcium has a big role with muscle contraction. And then magnesium has kind of a role with like relaxing the body in your cadence. And so those are really, really important. And we're losing those all in sweat. Those are all electrolytes. And so I would be really curious at things like sweat rate tests and that kind of thing with this athlete, just making sure that they're not losing what's, different than just standard electrolyte losses during their runs or hourly rates of fluid. And I see this a lot with ultra running too, especially depending on like what geographic region they're in. Are they at altitude? Are they in the south? Those kinds of things too. And so I would be really curious about those two pieces, that really the electrolytes. And then I would say probably last but certainly not least is that they're fueling their runs. As Kate has kind of talked about in past episodes too, when you have new mechanics or when you're working on things or coming back from injury, or if you're constantly re-spraining your ankles, then if you're doing like PT in between and your mechanics are changing, then your how you metabolize that glucose during your run is going to be expedited. And so making sure that he's hitting probably the higher ranges of fueling requirements, and then talking too about like all of this motor unit recruitment and stuff like that. That's a lot with your brain. And the number one substrate that the only substrate that passes the blood-brain barrier is glucose. And so high fueling needs during those ultra running. And I know like a lot of them are like, storage is tough. We don't want to carry handhelds. It's not convenient, but we got to do it.
I actually, that sets me up for a good story here. So I'm sure you guys have been in this scenario, or certainly we have audience members who've been in this scenario where you're doing like an out back and you're 5 miles out, and that's when you sprain your ankle, right? Like as far away as you could possibly be. So I think one thing we don't think about with underfueling, which you hit the nail on the head right there, is that our cognition is so important, and we need to be sharp, and our proprioception, our ability to know where our body is in space, and the ability for us to recover if we step on a twig and start to roll the ankle, that you're not gonna be able to recover from that as well when you're fatigued and tired. And so being able to fuel your body, I know this sounds silly, but it's really important for us to stay cognitively sharp and there and protect our bodies. I even think about the first running medicine doc that I worked with, and him having conversation with a patient of, and this is someone who wasn't a teenager, but was continuing to run to the 30s and 40s, and was to the point where it was like, it wasn't worth running through fatigue and exhaustion because of injury risk. So, hey, when you start feeling your mechanics break down, you walk, or you're done, or you switch to something low impact that reduces the risk of injury. And so that's not always exactly how we need to operate, but I do think it's really important to think about the cognition piece that comes with all of this in terms of being able to protect our bodies and prevent injury.
Yeah, it's like a safety thing, if anything, especially I talk about that a lot with cyclists too.
Yeah, I think that's actually a great point to the part that I was thinking about too, in terms of like mechanics and where you're running. If you're an ultra marathoner, most likely you're in the woods, you're on trails. It's the terrain is uneven. So you have to think about, I'm actually thinking about a patient that I had a long time ago. I love this guy. But anyway, he would be running, and he would constantly want to look down in his feet because he was worried that he was going to trip on the trails. But because he was looking down at his feet and not in front of him, he actually used to fall more. So one of the things that we worked on in PT was thinking about, like, where are we looking? What is our line of sight when we're running in the woods? And don't worry so much about where your foot is landing if you know you've got the mobility and you can do it, right? And so that instability of the terrain itself is something that we'll train in PT, and I'll make sure that people are aware that that's part of it. But then shoes come into play with that too. So if you're a trail runner, you probably wear trail running specific shoes, and there are a lot of different things that come into play with trail running shoes. Usually, the bottom of the shoe is a lot stiffer, so because of rocks and things like that, so that you don't get hurt. But also, a lot of times the stack height is a lot higher, and there's a little bit more cushion. So usually they're in that kind of moderate cushion, but their heel to toe drop might be 0. So heel to toe drop is the angle from the heel to the toe, whereas the stack height is overall how thick or how high are you off the ground, right? And so if you're high off the ground and you're a common ankle sprain person, you're more likely to sprain that ankle because you're already on this high platform. Then you're jumping around on the trail from one leg to another, trying to avoid rocks and sticks and other things. And so that's just something to think about. And it's something that I'll talk with my patients about when we're looking at shoes and looking at how they're moving and mechanics during this an evaluation or treatment for this particular issue.
And then one other tip I was going to mention too is for the athlete who comes in and they are complaining of ankle pain. I always worry about complications from folks who have chronic laxity and are not treating it. We can certainly get cartilage injuries within the ankle joint and other things that can end up being bigger issues than simply the laxity. Anytime that a joint is not functioning properly, oftentimes all the soft tissues around the joint are going to pay. And so sometimes it's ankle instability that's led to Achilles tendinopathy and tendon pain. So even if you have ankle instability today, but you have no symptoms, you still want to treat it. And I think it's so hard when that 16-year-old has an ankle sprain and they just want to go back at it and just forget it ever happened. We really want to make sure that we're educating athletes to go through that physical therapy piece of it.
Yeah, and just the stability component too, because like you said, it depends. If you're just spraining that ATFL, the first ligament, it's easy to kind of walk off. But if you are spraining more than one of those ligaments, sometimes you can also get that peroneal tendon will come in, and then you'll have a tendinopathy, or you'll have a peroneal tendon tear, or something else could happen. And then, people don't usually do anything unless there's a lot of swelling and they can't put weight on it. And if you're at that point, you definitely need to go in and see somebody. But even if you don't get to the point where there's a lot of swelling and it really hurts to put weight on it, you might just want to get it checked out. And at the very least, do some balance exercises for proprioception, do some strengthening for the foot and ankle. and make sure that you have good mobility in the foot and the ankle. And I say good mobility, knowing full well that you might have too much mobility on the lateral side of the ankle, but you might not have enough mobility in other places. Anything else, you guys? Yeah, go ahead.
I was just going to say, and we're talking about assumption that it sprains, but you can certainly fracture things. That's oftentimes when I see patients that come into clinic, they're 3 weeks later and they're like, this thing isn't getting any better. I'm like, because you fractured a bone. So making sure there's not something bigger going on as well. If you're having trouble weight bearing, that deserves additional workup.
That's a really good point. Especially when people have such high pain tolerance. And, again, they said, oh, I just sprained my ankle. It's no big deal. Yeah. All right. Well, that's all I really think I need to talk about for this particular injury. Why don't we go through and each of us say, 1 or 2 take-home messages, and then that'll be it. Who wants to go first? Kelsey?
I think that just not necessarily thinking about, on paper what fueling needs are, but just really respecting the things like the terrain and the weather and like where you're at in your fitness level too. And being okay with needing to adapt your hourly nutrition plan based on those variables and being flexible. Or if you're more fatigued from an earlier session in the week, I would say would be some of those things. And then I think too, like also if you're someone that's struggling to reel in hydration, there's hydration testing out there. So working with a professional to kind of reel in those hourly requirements for yourself.
Cool. Sarah?
I like to point out that this was a hip pain case that we talked about, ankle instability for the entire time. So pointing out the importance of that kinetic chain and how oftentimes a patient comes in with pain in one spot and I spend the entire time talking about another spot that essentially is fueling that particular pain. So like our common runner's knee where all we talk about is the hip, right? So just thinking about that whole kinetic chain and being able to address everything. And sometimes what doesn't hurt is actually what needs to be focused on more.
Oh, I love that. What I would like to say is that our foot hits the ground first when we run. And so if there's something going on at the foot and ankle and you're landing differently because of this chronic ankle sprain, it is going to translate all the way up into your body. And it's not just going to hinder you and cause missed training days. It could also decrease your performance. So it is something to take into consideration. And the second piece is, again, just remember, every time you sprain that ligament, you lose elasticity, you lose stability. And so if you can do something to help that, even if you're not in pain anymore, but you have a history of chronic ankle sprains, work on stability, work on single leg stuff, work on, stand on a balance pad while you're doing your RDLs, do something to build stability around that ankle and really focus on that foot and arch. Awesome. Well, thank you guys so much for listening. As always, if you like this episode, please share it with any coaches or friends or your running partner. If it speaks to you, we would love that. That's how this podcast continues to grow. We are so happy for all the listeners that we have gained. We're really starting to gain a lot, and we're so excited that people are finding this valuable. Again, if you have any questions, please email us at runCaseMiles@gmail.com, and we will get back to you. Usually we're a little bit slow, but we will definitely look at it once a week and respond to you. So we will talk to you later, and thank you so much for listening.